Hello, everyone, and thank you for joining us for this edition of the College of Nursing's new webinar series, Virtual Voices, Shaping the Future of Nursing. My name is Susan Kukic. I am the Director of Development and Alumni Relations for the College of Nursing, and I will be your host for this evening. Although this program is being presented in a webinar format, we'd like to hear from you. Please use the chat feature to let us know when you're tuning in from and your relationship to the College of Nursing. You may also use private chat to communicate with other participants during the program. Finally, we encourage you to use the question and answer feature to enter any questions you'd like our speakers to answer later on. In the event that we are not able to get to your question tonight, please know that we will provide an answer to you later this week. At this time, it is incumbent upon me to let you know that this program is being recorded. We are in the midst of a pandemic that has clearly magnified health disparities among racial and ethnic populations and the poor in our country. Our expert speakers this evening are here to highlight the disproportionate health risks and disparities facing one such population, gender and sexual minorities. I will be introducing our speakers to you in a few minutes, but first we thought we'd engage you in some polling around this important and timely subject. I will turn it over to College of Nursing Development and Alumni Relations staff member, Tatum Risch, who will lead us through a polling exercise.
Hello, everyone. We just have two very quick questions for you. So I will launch the poll and it will appear on your screen for you to be able to respond. I'll give everyone a few more seconds to submit their responses. And you should be able to see the results here. So for the first question, it looks as if most people did say that they know someone that identifies as a sexual and gender minority. So that just goes to show you just how important this topic is. And then for the response with what percentage of the general population identifies as sexual and gender minority individuals, the correct answer here, although there's many different numbers out there in the research, is between 5 to 10% and actually closer to the 10%. So thank you for participating, and we will dive into the introductions and the rest of the content.
Thank you, Tatum, and to everyone who participated. This evening's speakers are all assistant professors in the College of Nursing. Each is committed to using evidence-based science to develop and test healthcare techniques and to explore social, economic, and ethical issues that are the key to the adoption of best practices and to enacting positive structural change in the healthcare arena. Dr. Winnie Adebayo is passionate about improving the sexual health of youth through community-engaged research. Specifically, Dr. Adebayo's work revolves around sexual risk behaviors, access to and use of sexual health promotion resources, and sexually transmitted infection testing. Some of Dr. Adebayo's current projects are facilitators and barriers to self-initiated sexually transmitted infection testing among youth, developing a model for self-initiation of sexually transmitted infection testing among youth, and the sexual health needs and protective factors of sexual and gender minorities. Dr. Adebayo earned a Bachelor of Science in Nursing degree from South Carolina State University and a PhD at the University of Miami in Florida. We're also joined by Dr. Cara Exten, who is an infectious disease epidemiologist. Her research focuses on sexual minority health disparities and sexual health, specifically HIV and other sexually transmitted infections. Her work applies advanced statistical methods to better understand the complex factors that contribute to health disparities affecting sexual minority populations. She has extensive experience in working with vulnerable populations and is passionate about the examination of diseases through a biopsychosocial lens. Dr. Exten earned a Bachelor of Science degree from East Tennessee State University, a Master's in Public Health from Emory University, and a PhD from Ohio State University. Dr. BritneyWardecker is trained as a health psychologist, and her interests are in the areas of sexual and gender minority health and aging. She earned a Bachelor of Science degree here at Penn State, a PhD in psychology from the University of Michigan, and subsequently began training in the Center for Healthy Aging at Penn State as a postdoctoral fellow. Dr. Wardecker has developed a theoretically driven research program that uses psychological science to promote wellness and reduce social and health disparities among lesbian, gay, bisexual, transgender, and queer people. I recently interviewed these three experts on tonight's subject. Here's a recorded video of that conversation. So let's take a dive into this important topic by starting with a basic definition. Dr. Adebayo, can you define the terms sexual and gender minorities for our audience?
Absolutely. So the term sexual and gender minority can be used as an umbrella term to describe people whose sexual orientation and gender identity or even reproductive system doesn't adhere to the binary constructs that have been previously used to describe them. And so these are people who would not be considered cisgender or heterosexual, which is what is considered normative currently. So yes, that's what sexual and gender minority stands for.
Thank you. Dr. Exten, can you explain what some of the unique healthcare needs and outcomes of sexual and gender individuals are? And do those needs, whether they be physical or mental, differ across an individual's lifespan?
Yes, so the disparities we see impacting the sexual and gender minority communities are really diverse and widespread. And so almost any outcome that's been examined does disproportionately impact the sexual and gender minority populations. And usually I group these into three main categories. So you have the really biological outcomes like cardiovascular disease or sexually transmitted infections. You have the mental health outcomes, depression, anxiety, suicidality, things like that. And then you also have behavioral outcomes like substance abuse. And those ones that I just mentioned are all known to disproportionately impact sexual and gender minority individuals. And it does vary across the lifespan. We know that there are certain periods in the life course when sexual and gender minority individuals are most at risk of developing these outcomes. But each outcome has a little bit of a different story. And it's important to note also that the sexual and gender minority population is heterogeneous within itself. And so it impacts sexual and gender minorities of color in a different way than white sexual and gender minorities. And males and females may be impacted in different ways. And so it's a very complex story, but what we do know is that they are more at risk for many, many health outcomes across their life course.
Dr. Wardecker, how do you define the concept of disparities in access to quality care for sexual and gender minority individuals? And what are some of the barriers that prevent individuals from seeking and accessing healthcare in the first place?
Sure, yeah, thanks. So thank you for having us. So I would define the concepts of disparities in access to quality of care as social and economic barriers that exist for sexual and gender minority individuals across their lifespan. And these are likely as a result of historical marginalization, discrimination, and exclusion that occur for, or that sexual and gender minority individuals experience. So we know that just some examples, sexual and gender minorities are much less likely to be able to find a healthcare provider because of their sexual orientation. So oftentimes they may be refused treatment or enter a situation where they feel a provider is not inclusive of them. There are, and we know that fear and mistrust in the healthcare system for LGBTQ, that's lesbian, gay, bisexual, transgender, and queer individuals, which is all under the sexual and gender minority umbrella, do have a fear of and mistrust of healthcare providers and healthcare systems. And some examples of that are, we can pull from a lot of examples, but just historically, so just up until 1973, which is relatively recent, identifying as homosexual was as the term that was used at that time, or having a same-sex attraction or behavior was diagnosed as a mental illness in the Statistic and Diagnostic Manual of Mental Disorders. And so as a result of those experiences, LGBTQ people, have a fear and mistrust of seeking treatment. So as I think we'll talk about later, there are some things that we can do as healthcare providers and systems and structures to try to eliminate those barriers and also establish trust with the LGBT community.
Well, it's clear that given what you've just said, that this is really an important and timely conversation that we're having here. I wanted to switch into your areas of research and the topics that you're passionate about. Dr. Adebayo, would you like to begin by sharing your passions for this area of work?
Absolutely. And so my area of interest is sexual health promotion and decreasing the burden of STI and HIV among young people. When I started this work, I actually saw very early on that the burden was even higher among young people who identify as sexual and gender minority, way back to when I fell in love with this work as an undergrad student, quite honestly. And one of the things that I hope that my body of work hopes to accomplish is to focus on identifying like unique experiences, unique shared experiences, areas for tailored interventions. And really, there's this mantra that I work with, and which is there's no one size fits all in healthcare. And the fact that we've been trying to do it that way in the past shows that we've been doing something wrong. And so I hope that our work really starts to get at addressing the unique needs of sexual and gender minority as it pertains to what I do, which is sexual health promotion and reducing STI and HIV burden. I really hope that in the future we can see that members of this community and this population experience lower or less health disparities and are healthier and living happy lives, really. So yeah.
Dr. Exten, would you like to share?
Sure. So I'm an infectious disease epidemiologist by training. And so I really came into this work through the examination of HIV and sexually transmitted infections, which are traditionally the diseases that were first sort of associated with disproportionately impacting the sexual and gender minority communities. And I started in that field, and I quickly understood that there was just a much more complex story to the health of this population. And so I spend a lot of time thinking about what leads to HIV and sexually transmitted infections and unique risk factors. And what we know among sexual and gender minority communities is that their behavior is impacted by a complex structure that has psychological and social determinants. Mainly discrimination is one of the primary things I look at. And we look at how discrimination impacts individuals and the way they feel and the way they behave, and how those things then lead to these poor health outcomes. And so it's a much more complex story than I think we were talking about many years ago when we were thinking that they just had more of this disease. And that we now understand that these outcomes are really the result of a complex sort of cascade of things that happened after discrimination.
And Dr. Wardecker.
Sure. So yeah, my research, I would say, intersects a lot with Dr. Adebayo and Exten. We often work together on similar themes. Where mine might diverge a bit is my interest is in older sexual and gender minorities. So older sexual and gender minorities are categorized in the research as people who identify as LGBTQ and are ages 50 and older. And so that group of individuals is even more marginalized within the SGM population because of their age and historical experiences. And so kind of to tie in what I mentioned earlier, one of the things that might characterize the lives of older LGBT adults differently compared to younger LGBT adults is that older adults likely couldn't marry in their lifetime when they were coming of age until until marriage was legalized in around 2015. And so now we have groups of younger LGBTQ adults that may likely be able to get married, but then might also face a host of other different disparities. And so some of my work looks at those differences and what they might predict in terms of health and linking them to health. And also, I think with my colleagues as well, we all kind of prioritize health disparities in a way that is a kind of a public health concern. So it's something I think that all people should be concerned about, and not specifically towards sexual and gender minorities, but as Dr. Adebayo mentioned, it's sort of, I think, a new framework to be thinking about person-centered care. So what are the differences or tailored interventions that we can have for different people and different groups of people? And we all happen to study sexual and gender minorities, but it's thinking about those groups and whether they, disproportionately experience certain health risks differently, or behaviors differently, or experiences differently. And then trying to personalize care so that those individuals feel heard and trusted, and showing empathy towards specific groups.
This is for all of you. How can frontline healthcare providers, like the alumni and other providers who might be tuning in for this program right now, work within their healthcare systems to foster a culture of awareness and understanding about the unique needs of sexual and gender minorities? Dr. Wardecker, would you like to start?
Sure, yeah, I can start. So there are a group of things that we know can work to make LGBTQ people of all ages feel more comfortable and like their experiences and health needs are being heard. And so one is healthcare providers can make sure that ingrained in their training or in their institutions or systems that there is cultural competency training. And that can come in many different ways, but oftentimes it's very important, if that's the case, to either bring in somebody outside who is an expert in SGM lives and experiences, and also making sure that SGM people and people who identify as SGM are included in those trainings, and that their experiences are provided as examples, and so that they can also give feedback in terms of how they would like to receive treatment. It's oftentimes hard for us to figure those things out unless we hear those voices and then tailor to those needs. Other things are inclusive language, so trying to avoid social assumptions. So if people come in together, let's say a male and people who identify as male and female come in together, often we may assume that those individuals are married and that one is a husband and one is a wife. So trying to avoid those social assumptions that they're paired, or that one is naturally husband or wife. And so some other quick things are cues of inclusivity. Sometimes healthcare settings will include brochures on tables that include same-sex couples, or healthcare providers might wear pins. So for the SGM community, a rainbow is a sign of pride or LGBTQ pride. So healthcare providers may choose to wear something like that that signals that they can be trusted or that they're inclusive of individuals of all sexual and gender minorities. But it is important for us to think about, because over half of the LGBT community does report discrimination from healthcare providers. And these negative experiences can happen across the board. So one thing I always like to mention as well is that it's not just healthcare providers, but it's the people that are also in these healthcare situations. So you think about someone showing up to, let's say, a doctor's appointment, and they might encounter a parking attendant first, and then someone sitting at a desk second, and then maybe a janitor third before they even reach a healthcare provider. And if there are any negative experiences that happen even before a healthcare provider is reached, that could deter LGBTQ people from going into or being comfortable in their situation. So those are just some examples. So making sure that training is across the board and not just for healthcare providers.
Dr. Adebayo, do you have anything to add to that?
I mean, Dr. Wardecker did an excellent job breaking this down. I work very well with acronyms. It helps me remember things. And so when I think about what we can do or what we can keep doing, I think about a CAP. And so it's like if you're trying to get somewhere fast or, go from point A to point B, you take a cab. And so C stands for communication. And just like Dr. Wardecker said, like really having not just open communications, among ourselves, but when we meet people, having open communication. And the key thing that defines open communication is not making any assumptions at all. And the next thing is advocacy, like speaking up. I was reading something recently, about the little things that we do that we don't take note of. And so like really making it a point of duty to speak up and advocate for members of the SGM community. Not laughing at inappropriate jokes, not making them, not letting things, just slide because we have a culture that makes that okay. Like speaking up, saying something, and really owning that in your workplace and in the way you treat people. And thirdly, B is for boosting efforts to do this, research efforts, efforts that we see with other organizations that advocate on a larger scale, like supporting those activities and really joining hands with things that already exist and just being boosts. And even things as simple as sharing the correct information on your Facebook page or your social media page, and making it a point of duty to lift up members of this community. I think those little things every day make a difference, even before we talk about what we're doing as researchers and healthcare professionals to make a difference.
Dr. Exten, we'll start with you with this question. How could nursing curricula, especially at the undergraduate level, be changed to improve health outcomes for gender and sexual minority individuals?
Thanks. So, it's something I think about a lot is how can we change the future? We know that we haven't always done a great job in educating healthcare providers in how to care for diverse communities. And as my colleagues have mentioned, this is something we're all really passionate about. And it's one of the primary reasons I think we all ended up here in a College of Nursing is this real desire to change healthcare for the future. I think one of the first steps that ties directly to my line of thinking is really thinking about health from a biological, psychological, and social perspective. So this biopsychosocial approach to health. So really thinking about training nurses to examine the entirety of a person, to take a holistic approach instead of just looking at them biologically and the blood pressure and the things that we're all so familiar with as measures of health, but to think about their psychological status and their social environment, and to think about all of those things as just as equal contributors to their health as their blood pressure and their weight. And I think that that's just a shift that we need to make in healthcare, because when you look at someone who's a member of a diverse community and if you examine all those factors, you recognize that they're at increased risk for mental health outcomes. You recognize that they may be experiencing discrimination and stigma in their everyday life. They may be living in unsafe situations. They may not have the same opportunities to engage in some of the health the health-seeking behaviors that many people are able to because of their social status. And so I think that that, to me, is the first step, is really embracing this idea that we have to look at determinants of health in a holistic way.
Dr. Adebayo or Dr. Wardecker, do you have anything to add?
Sure, I can add, and then Dr. Adebayo, you can take it away. Just very quickly for me, I think one of the ways that we can increase undergraduate education is, one thing we know is that medical schools, so this is beyond even undergraduate education, but medical schools, even so then you think of the upper level education, devote less than 5 hours in their entire curriculum to LGBT related issues. And so that seems, to me, very low. So I think we can, think about increasing those hours, but also doing it earlier in the career trajectory. So incorporating that type of work and experience in the undergraduate, at the undergraduate level. And then also less than 10% of US hospitals and academic settings are designated as leaders in LGBTQ equality. So you can actually get that status through the Human Rights Campaign organization. And so I think thinking, teaching people about that early to figure out how to get their institutions up to that level and status is really important, and providing awareness for that early on in people's education.
And to Dr. Exten and Dr. Wardecker have done a great job. I just want to add this. The first time I took care of a transgender patient after nursing school was also the first time I was hearing anything about, someone being transgender and their care and what they needed. And all the training I had was the charge nurse pulling me aside before I walked in the room and saying, "You're about to go in. This is what you need to know. This is how to address them. Take it away." And when I think about that, it's terrible. It's terrible that I was already a graduate, I was already licensed, and I had absolutely no training on how to care for people who were sexual and gender diverse. And I hope no other nurse gets to say that again.
I can just add one thing, sorry, because I always add this statistic because I think it's really striking, and it really adds to what Dr. Adebayo just said. There are just as many individuals in the United States who are transgender as have juvenile diabetes. And no one ever expects that. And you would never, ever dream of letting someone graduate from nursing school or medical school without understanding how to assess and treat juvenile diabetes. But somehow we've evolved to let it be okay that there are medical providers who haven't been trained in how to treat transgender individuals. And I think that those are the disparities that we know are there that we are all really passionate about fixing.
Well, I mean, I can't tell you how much I've appreciated you joining us here, and sharing your insights based upon your studies and your research, your personal experience. We're going to transition now to the Q&A portion of the event. Yes, we'll now transition to the Q&A portion of the event. So I'll turn it over to Drs. Adebayo, Exten, and Wardecker, and College of Nursing Development and Alumni Relations team member Julie Connor, who will moderate the Q&A session.
Thanks, Susan. So we had some questions that were submitted in advance, but feel free to continue to enter questions into the Q&A feature. So our first question is, how transferable are best practices for sexual and gender minorities to pediatric populations, specifically for individuals facing social and racial inequities in healthcare?
That's a loaded question. Please repeat it one more time.
Sure. So how transferable are best practices for sexual and gender minorities to pediatric populations, specifically for individuals facing social and racial inequities in healthcare?
Which one of you wants to take it?
This is a stumper, like first out of the gate. Like I was like, let it be a softball first, but it's not. No, so I think, of course, pediatrics is also a unique population, and so we always have to be mindful. And I think the three of us certainly are not pediatric experts. Dr. Adebayo works with youth more than I think Dr. Wardecker or I both. But, I think in a general rule, a lot of what we're talking about does apply to pediatric populations. What we're talking about is being inclusive, being accepting, being compassionate, being understanding of the unique needs of a population. And I think that holds true across age. And what we know is that the disparities that we find among adults often start in childhood. So that's not the focus of a lot of my work, but what we know is that often the substance abuse disparities and the mental health disparities, and even some of the biological health disparities, we see in early adolescence starting to crop up, where sexual and gender minority individuals really do face those issues from a very young age.
Yeah, I would agree. And I think the things that we've discussed, inclusive language and, cues of inclusivity, not making social assumptions, are all across the board helpful for anyone who is LGBTQ, regardless of age. So I think we're thinking about targeting structures and systems and having them change. So one thing I say all the time, and my colleagues probably think I'm a broken record, but I always say health disparities aren't born in the body. So you aren't born with a health disparity. They exist and they develop because of structures and systems that create negative experiences for people and added stress. And so I think, again, the things that we're talking about are really significant for people of all ages.
Just to add a little thing, I like to think about things at the micro level, which is what I can do and what you can do, versus at a macro level, which always seems like a web of craziness in my head. And so if I think about it that way, how transferable are best practices? Very transferable, because when they meet you, you have the training, you're interested in learning, you're interested in providing the best possible care and best possible interaction. That's you transferring best practices. And so it is our responsibility as healthcare professionals or people who are interested in seeing things change in the sexual and gender minority population to learn, to grow, to be involved, to put ourselves right in the middle and the heart of the problem and make a difference. So if I think about it that way, then the answer is very transferable.
Great, thank you. So our next question is, how has COVID-19 widened the health disparities experienced by sexual and gender minorities?
Cara, this is all you. Cara's been leading or heading a lot of the COVID-related work in our department.
So I can talk about this briefly, but I actually sometimes feel like I am at a place where I can only see the forest and I'm not seeing the trees so well some days. But COVID-19 has had a massive impact on our society as a whole, and particularly an impact on healthcare. And so we all had the experience of being unable to access healthcare for many months. Some of America is back in that scenario where, things, non-elective procedures are canceled. It's hard to get into a doctor's office, and it feels unsafe to go to a doctor in some areas. And for sexual and gender minority communities who already have a very challenging time accessing healthcare, to go through this period where they have this extra barrier, we know is going to increase disparities. What we also know from some of the research that's coming out about COVID-19 is it has increased a lot of the healthcare issues that impact sexual and gender minorities the most. So we're seeing rates of STDs increase, we're seeing rates of HIV increase, because a lot of the same clinics and a lot of the same healthcare providers that provide typical care for those types of infections at public health departments and community clinics, those have transitioned to be COVID-19 centers in the face of this pandemic. And so there's a lack of access to care. There's increased infection in the community of all these different infections. So sorry, I'm gonna let somebody else pick it up from here because I'm just rambling now.
Cara, that's a great point. And I think very quickly, one other thing to mention is that historically, LGBTQ people have relied on families of choice. And so these aren't people that are biologically or legally tied to them, like we might think of for some of us who maybe have quarantine. Likely we might be with family or people who are inside our family systems, our homes. And LGBTQ people, especially older ones, face history of discrimination, and many may have been rejected from their family, and so may not be quite as much in touch with legal and biological ties. So many of them rely on families of choice, which are people that you kind of select to play those roles. And so because of social distancing, they may not quite have as much access as they used to, or as we might if we have family and biological ties that are kind of living in our homestead. And so I think one thing that we found is rates of loneliness have really skyrocketed, and they're already higher for LGBTQ older adults, but there's been some things put in place to try to eliminate loneliness in the LGBTQ community, particularly older adults. And so I think that's another way, is kind of these intersecting psychological things that are occurring with already being a marginalized population and then experiencing a pandemic.
Okay, great. So this next question relates to something that you just mentioned, Dr. Wardecker. So support from loved ones while facing health challenges is critically important on so many levels, but I have heard that the partners of LGBTQ individuals are sometimes discriminated against. Can you address the concept of families of choice?
Yeah, sure. Do you want me to go again, Winnie or Cara? Okay. Sorry, I don't want to take up too much time. So families of choice are exactly what I mentioned, are not legal and biological ties, but generally family systems that have developed over time to play those roles. So actually some interesting statistics are LGBTQ people tend to, this may be surprising, but they tend to have stayed close friends with people they may have dated in life or married in life, because the community is so small that people tend to try to hold on to their social ties. So that's generally the type of families of choice people have. They might be ex-relationship partners or neighbors or other people that have taken part in their lives. And with regard to partners being stigmatized, I think that's generally true just for LGBTQ couples in general. I don't think it's a partner thing. I think it's kind of the orientation of an individual. And obviously a lot of it depends on people's level of outness or their identity or the way that they look, or there's a lot of intersecting factors there with how people experience discrimination, why they experience discrimination. But I'm not sure that it's quite, I mean, maybe this question also stems from healthcare scenarios. And yes, I think that's true in healthcare settings, that partners in LGBT couples may not always be acknowledged. They may not be the first person that a healthcare provider goes to for telling them information for how to take care of somebody. And so these are the things that we have to think about as being inclusive. Who is going to be with these people? It might be a neighbor, and is that going to be okay to share information with them if they're not, a legal biological tie? So these are the things that we all think about.
So we had, I think we have time for one more question. So how has the reduction of centers such as Planned Parenthood affected services to gender minorities?
Winnie, you want to take it away?
And I'm going to speak about this mostly from my study because I have asked questions like this about access to care and how people are getting those resources. And so the answer is significantly. Just like Britt has said, or Dr. Wardecker has said, and Cara has said, Dr. Exten has said. Okay, I'll behave. Just like we have talked about, like members of the sexual and gender minority community tend to experience stigma, discrimination, fear of reactions. And so they have very few places that they go to where they are safe and accepted and where nobody makes assumptions about them and people are open and asking questions and really trying to meet their needs. And when places like Planned Parenthoods that are getting closed down, it reduced the number of places, or it reduced those safe spaces for people in the SGM community. And that led to really widening the health disparities that we have been talking about today and trying to, address. Um, I'll give you an example. I was going through some of my data and pulled out so many quotes that of people who have been to a clinician who has never actually asked them about their sexual orientation. And so they see them and then automatically assume that they have a partner of the opposite gender. And then all the sexual health assessment that they get is, do you have a boyfriend, or do you have a girlfriend, or do you have this or that? And that person responds no, because really the answer is no. They have a same-sex partner, or they have a partner who is of the gender that the clinician is not assessing. And the clinician moves on. It's like, okay, great, let's go to the next thing. And doesn't follow up, doesn't ask further questions, doesn't provide resources or counseling or whatever they might need to be healthy. And so when you have places like Planned Parenthood who have been embedded in the community and have people who are trained to meet those needs, to ask those questions, to provide tailored care. When you have places like that getting closed down, you expose members of the SGM community back out to risk, back out to lack of healthcare resources, and back out to, having worse health outcomes. And yeah, that wasn't good at all.
Great, thank you. I think at this point, I will turn it back over to Susan to offer some concluding remarks.
Well, thank you, Julie and Drs. Adebayo, Exten, and Wardecker. We look forward to a time when your efforts to advance health, healing, and equity for sexual and gender minorities are fully integrated and normalized in our education and healthcare landscapes. And thanks to all of you for joining us this evening. We hope you have enjoyed the content presented and that you will take a few minutes to complete the program assessment survey that you will be receiving later this week. For the glory of Old State, and on behalf of the College of Nursing, we wish you all a very good night.